هو دكتور احمد لما بين الفيديو بتاعه في 2 تيبس انا شفتهم عجبوني احب هايلايت ذم. اول حاجه الديكورتيكيشن بتاعت الابر واللور انسترومنتد ليفلز عشان انت عاوز هنا تكريت فيوجن. تاني حاجه وهو بيعمل ديستراكشن، لو خدتوا بالكم هو ما عملش ديستراكشن على المسامير، يعني نيفر ان انت تحاول تعمل ديستراكشن على المسامير. هي على دومينو وحط الباور جريب ويديستراكت على الدومينو، يعني يو هاف كونستراكت انت بتديستراكت عليه بروكسيمالي وكونستراكت بتديستراكت عليه ديستالي. دي بيديك بريفليج ان انت ما يحصلكش لوزننج في المسامير بتاعتك بعد كده. شكرا جزيلا دكتور احمد. اعتقد جوزيف هايلايتد ذا امبورتنس اوف ان احنا نفكر ازاي تو افويد ان انت تدخل بالعيان كذا سيرجري وده بيأفكت البرين، بس طبعا ده على غرار الكوست. فهل في طريقه ممكن ان احنا ناخد الحسنيين، ان احنا نقلل العيان ان هو يحصل له لينسننج وجروس موديوليشن وفي نفس الوقت بتشيبر واي ان احنا ما ندخلش كل 6 شهور نعمل لينسننج ولا عندنا الماجيك رود الغالي؟ فده اللي ممكن يوريه لنا دكتور سامي في البرزنتيشن اللي جايه عن الاكتيف ايبيكال كنترول.
Good afternoon everybody. Thank you for the Dr. Khattab and the organizing committee. The issue of the EOS or early onset scoliosis will never end. It is there is no magic secret about or magic solution for the management of the early onset scoliosis. I will make it short. The deformity have been summated early onset less than 10 years old, whether it is idiopathic, syndromic, according to the SRS or the juvenile type. Why we do have to manage? Because to stop the progression and to maximize thoracic volume, which is very important, especially in the first 5-6 years. And the last 2 points, acceptable correction. It's not the ideal correction, but it's the acceptable one, and preserving spinal growth. As we see here, how much the patient is alveoli formation and growing of the thorax is important in the first 5 years, and the more important up to 10 years. And this is the causes of morbidity and even mortality if the patient have not been managed. There are many issues and many trials that you should do and try before you go for surgery, like casting, like bracing, to delay or avoid surgery, to modulate and to maintain the thoracic volume. Surgical techniques briefly can be a distraction-based, compression-based, or growth guidance, as we mentioned. Harrington with 962 with Harrington rod was the first to use in a distraction way for early onset scoliosis, followed by Luki and in Luki Trolley. Then Roy Camille introduced the pedicle screws, which have jumped in the issue and revolutionary in the issue management of scoliosis. Then McCarthy and Asher make the Sheila technique in about 2010, 2014 to make a modulation in the way for early onset scoliosis management. The issue of the traction way is the crankshaft phenomena, like discovered by Dupuy. And then Sanders also have the issue of identifying the gross with the Reaser classification and open triad. So those 2 important issues to when to go for surgery are either temporary or growing rod system or to permanent fixation according to the bone maturity. The distraction way we can use Vector or use the spine distraction growing rod systems. But each one of them have a selective and indication and contraindication. Another way is the growing rod system. It can be used in multiple surgeries, but there is risk of infection, rod breakage, and spine stiffness. This is the TGR, which is distraction based. You have to apply screws as a proximal and distal anchors, then followed by the dominoes as a connection with distraction every 3 to 6 months. Convex growth arrestance is one of compression based, where they do controlling the growth of the convex side may stop the aberration and also lead to further spontaneous correction, provided that the concave side has remained in the growth potential. But however, this is unpredictable how much, so there might be overcorrection on the other side. And sometimes it used unilateral fixation, or sometimes hybrid with another growing rod on the other side. But the issue in this way, it is unpredictable, and it can happen inversion in the curve on the other side. The issue of the growing system is that there are large 3D residual deformity at the apex, which was the correction, less spine growth, and higher complication rate, increased need for osteotomy in the final surgery. So there have been the growth modulation either by the magnetic rod or the APC, active apex correction, or the growth guidance technique like the Sheila one. I will shift to make it short. The growth guidance technique of Sheila is clinically acceptable alternative for distraction-based growth, but has two major advantages. Although it is very good, but there is still crankshaft in the Sheila technique. Even McCarthy himself in his literature mentions there is a failure of the, to achieve marvelous results, and there is a complication, and there is crankshaft, as you see here. Then our dear friend Dr. Ala Azmi adopted a new innovation technique that tried to make control of the apex, because all the problem with the early onset and the crankshaft and all the issue is the apex, the derotation. And even when we do in adolescent type, when you with the innovation of the derotation techniques, you achieve much better reasonable correction of the apex and the deformity correction in the axial rotation. So the idea of the APC, or active apex control, it is a modified Sheila technique. Instead of fixing the apex and going with mobile sliding as the proximal distal, he applied fixation at the upper and lower anchors and had the mobility at the apex with screws at the convex side, 2 screws at the apex, and the apex is included by 3 vertebrae. The wedges, the most wedged vertebrae, and 1 level above and 1 level below. And you do 2 both screws at the those 1 above and 1 below the apex, and you do derotation and compression at this apex, including applying dominance and connectors like here in this picture. It allows active compression-based intervention at the apex, as I mentioned, using the Volkmann law with reverse modulation, passively restrained guided growth height allowance of the entire scoliotic curve that will decrease the incidence of crankshaft. For example, in this case, as you see here, we put the central sacral vertical line, identify the apex of the curve, then we go 1 screw above and 1 screw below as the apex, and those screws are compressed and derotated, either with the derotation or any instrument you have. Then you have to both upper and lower anchors here. You connect those with dominoes, as is in this picture, and with the dominoes you do distraction at the concave side and just connection on the other side without any distraction. You have to leave a little 4 or 5 centimeters for allowing of gross modulation. Then you do distraction at the concave side, and this is the patient post-operatively. Does it solve a problem? For sure, it helps, but as we mentioned, this is not the magical solution of the early onset. There is still complications, there is still infections, there is still adding on, they still pull out the screws, even with this technique. It's aimed to pathologic apex rather than global distraction. It is promising potential advantages, especially it is very important as a socio-economic issue. It's much cheaper than any other. For sure, the magnetic rod, even it is debatable about its socio-economic value for money. Even in European countries, there is a major concern about the magic rod now, magic rod. I even use it nowadays in some cases of early onset or juvenile scoliosis. This patient is about 9 years old, and I applied something like growing system, and this 1 year follow-up, and the patient is doing well. This is a paper in the literature about the 2 years follow-up about the apex, active apex control by Dr. Ala Azmi and his group from multi-centers, and they show that there is significant improvement in the results, and they found that there is no fusion at the facet joint in this paper. What is against the APC? It is limited long-term evidence, so we cannot confirm this is the best result. The heterogeneity of the technique, it is modified Sheila, or this is other technique. Complication and intended fusion at the apex have been observed in some papers in the literature, not necessarily superior to established growth-friendly options in robust comparative data. I will show a limited number of cases. This is a 10 years old female patient with juvenile idiopathic, with the curve about 49 degrees. For sure, I go for surgery after trial of physiotherapy, Schross method, bracing, and those patients came, they tell me about we have 6 or 9 months and the curve are progressing, and we failed with bracing and even physiotherapy. And there is significant scoliosis here. kyphosis 82 degrees. We identify our apex, as we mentioned, and we applied it. I use usually, this case was not Wilsey, but I use Wilsey technique in applying the upper and even lower anchors. And this is the patient post-operatively, and this is her even improvement of the kyphosis. But and here with the X-ray after 1 year, there is growth on the concave side, as we see at the X-rays. However, the patient post-operatively have PGK, but in general, the patient is stable, not complaining of any neck pain, and she is happy, so I will not attack or do any revision unless she is suffering. Second case, male, 5 years old, 55 degrees with 87 degrees kyphosis, and this is a patient post-operatively and improvement of the kyphosis and the scoliosis. Third case is a 4 years old with 72 degrees main thoracic curve and 55 degrees of thoracic kyphosis, and we did growing rod system, and there is gradual or reasonable and good correction. So who is the best candidate for this technique? I think young children with progressive early onset is the best candidate for this, with focused correction. Growth preservation is a priority. When repeated magnetically controlled distraction or using other approaches failed to achieve good correction for the patient. What about severe rigid congenital structure? I don't recommend APC in the rigid curves. I don't recommend it in severe hyperkyphosis with scoliosis. And it's very young patient try to use casting or bracing to avoid doing it in a very young patient, because low immunity, there might be infection, and cases where long-term data are essential for decision making. This is one of our cases. It was advanced case with severe curve, with severe kyphosis, angular kyphosis, as you see here. It's about 7 years old. We tried to do with the patient, which have good balance in the images post-operatively, but 9 months later, the patient, although the screws are in place and the patient looks fine, everything looks fine, but there is truncal and coronal imbalance in this patient, and I think she needs surgery. So our conclusion, safe and viable option in surgical management in early scoliosis is the APC. Effective in reverse modulating the APIC region. Short-term outcome is promising. Future long-term studies are needed for better understanding of the clinical and neurological outcome of and their sustainability. Appropriate selection of candidate is fundamental. Thank you very much.
شكرا جزيلا دكتور سامر. Comments. عمرو.
Thank you Dr. Samer for the nice presentation. أنا عندي كومنت على حضرتك قلت إن حضرتك بتستخدم bracing وشورت ميثود قبل ما اوفر السيرجري يعني. هل حضرتك شايف ليهم benefit في الايرلي اونست؟ يعني بنسمع عنهم اكتر او بنستخدمهم اكتر في الادوليسنس. هل حضرتك اوير بستاديز لقيت ان هي valuable في الايرلي اونست؟
البريسنج
الفيزيوثيرابي الشورت ميثود.
We are trying everything with the patients. You are trying everything to postpone surgery. So this is our using of the physiotherapy is one of our tools with bracing to avoid surgery, strengthening the muscle, flexibility of the curve. So it is a trial.
In your experience, in your own cases, حضرتك لقيت ليها value?
About 60% failure of physiotherapy, 60 or 70%. But sometimes the patients are afraid of surgery because this patient, I will take from Dr. Joseph mentioned, multiple surgeries in young age, psychologically and cognitively affecting this patient. So we try to postpone it, try minimize it.
شكرا على المحاضرة القيمة. هو الكاستنج يعني في كل النونس النون اوبراتيف كاستنج بيفور ذا ايج اوف 6 years. احنا يعني الحمد لله شغالين كتير كاستنج. كان الخوف ان هم دونت توليريت الهوت ويزرد في الصعيد، لا يعني توليريت، ولما العيان بتقنعه انه هيتحسن وانه ده كويس لا بيفضل حتى ايفن في الفيري هوت 7 و8، فده بيدي نتيجه كويسه جدا ايفن في الكونجينيتال بناخد لانه اتليست كنترولز السكندري كيرفز، اتليست تايم باينج تاكتيك لحد يعني زي البنت دي احنا تايم باينج من شفناها من سنه و9 شهور اشتغلناها تقريبا عند 6 سنين. ف it is a very good chance انك انت كنترول
Even
العيان.
if the curve is 70 or 80 degrees you go for casting.
والله انا يعني خدت الديسيجن لما يعني ان هي كانت اتاخرت عليا في مره تقريبا عدت سنه كامله ما جاتنيش، فانا خدت الديسيجن اول ما شفت الكيرف كده. شكرا.
شكرا جزيلا دكتور سامر. I'd like to comment على حاجتين. اول حاجه هو دايما الدومينو ما بنحطهاش فوق الدومينو، بنحاول نحطها عند السوراكو لامبر جانكشن عشان نحاول الرد تبقى في الحته دي ستريت، ما يبقاش عامله اي امبنجمنت او جامنج. دي اول حاجه، لان انا كنت شايف في حاله عرضتها كنت حاطط
هو
الدومينو فوق.
في تو تكنيكس في الاي بي سي. في موديفيكيشن اتعمل جديد جاست ديستال، بس انت كنت بتعمل 3 رودز على الناحيه كونفكس بحيث ان انت تدي فرصه ان يحصل جروينج برضه للبروكسيمال، ما يبقاش ان انت عملت ليميتيشن لجروث اوف ذا بروكسيمال كونستراكشن ويبقى جاست ديبندينج اون ذا ديستال كونستراكت اونلي. لانك لو ثبت البروكسيمال بالايبكس ثبتهم ببعض خلاص كل من تي 2 لغايه تي 12 دول مش هيثبتوا.
هو يعني خلينا نبقى ندسكاس دي اكتر. احنا بنعمل ويبينارز فريكوينتلي للاي بي سي فانز جروب، وبيبقى عليها حاجات كده موديفيكيشنز اللي بيقولها دكتور سامر، بس ان جنرال هو الاستراتيجي ان احنا دايما بنحطها في النص. تاني حاجه برضو معلش يا سامر، العيانه اللي حصل لها بروكسيمال جانكشنال فيلير دي اي نيفر ليف لوز سكرو في عيان. مفيش حاجه اسمها انا هستنى ولو جالي بعدين. لوز سكرو هيتنيه توجل، هيبقى الريفيجن بتاعك صعب وبيصعب عليك الدنيا. وانت ان انت بدات تلاقي كونستراكت فيلير جو انترفين ودي العيان البيست تشانس، لان هي المسامير دي لو يعني ربنا كرمنا وخرجت بره، انما لو خرجت وكانت كونفرجنت ورجعت لورا كده هتبقى قصه كبيره. يعني ممكن تعمل نيورولوجيكال. شكرا جزيلا دكتور سامر.